Our next presenter is Dr. Reema Hasan. Dr. Reema Hasan is a heart failure and transplant cardiologist who currently sees patients at the University of Michigan Cardiovascular Center and the University of Michigan Livonia Health Center. Before joining the cardiology team at the University of Michigan, Dr. Hasan received her medical degree from the American University of the Caribbean. She completed her internal medicine residency at Henry Ford Health System in Detroit, Michigan, and then completed her cardiology fellowship at Providence Hospital in Southfield, Michigan. She then subsequently completed her subspecialty training in heart failure and cardiac transplant at the University of Michigan. She believes that this diverse background, starting on an island with a 30-mile radius to passing through urban and suburban centers, has helped her understand a diverse patient population and has allowed her to become the physician she is today. She values the importance of doctor-patient relationship and patient and family-centered care. Dr. Hasan, thank you for joining us.
Thank you, Sarah. Welcome, everyone, and thank you for having me. So the next discussion is going to be revolved around what we do when we start an LVAD workup. So the topics of discussion today are going to include identifying patients highest at risk, which I know Dr. Battar briefly discussed in his lecture, and then sort of going over that window of opportunity in which we can implant a patient with a end-stage heart failure, as well as sort of going over specific criteria to decide when to consider VAD therapy and what do we actually, what studies do we actually order involved in the LVAD workup. So looking at sort of the continuum of care from assessing a patient to implantation of the VAD, in my opinion, the most important part of this process is really patient selection and pre-implant optimization. We want to guarantee that we have a successful implantation of a VAD and that patients go on to have a successful course with their VAD therapy. And so really focusing on who are the patients we choose for VAD versus cardiac transplantation and how we optimize them prior to surgery is a huge part of what we do to ensure the success. The European Society of Cardiology defines advanced heart failure with the 6 next points. So they consider patients with advanced heart failure who have New York Heart Association class 3 or 4 symptoms, patients who do have episodes of fluid retention and reduced cardiac output at rest. They have to have at least one of the following: an EF of less than 30%, echo findings suggestive of pseudonormal or restrictive mitral inflow pattern. Their pulmonary capillary wedge pressure has to be greater than 16 or an RA pressure greater than 12 by right heart catheterization, and they have to have elevated BNP levels or NT-pro and BNP levels. They need to show some functional capacity decline in terms of inability to exercise, a 6-minute walk distance that's less than 300 meters, or an exercise VO2 study metabolic stress test showing a peak VO2 of less than 12 to 14. These patients usually have at least one heart failure hospitalization or more in the last 6 months, and they need to have been tried at least to be optimized on guideline-directed medical therapy. Now, the American College of Cardiology and American Heart Association considers the following sort of risk factors for patients with advanced heart failure. So anyone who has been hospitalized or more than 2 times in the past year, patients who have a deterioration in renal function suggestive of a rise in BUN and creatinine, patients who have ongoing weight loss with advanced heart failure and can demonstrate cardiac cachexia, patients who are intolerant to ACE inhibitors or beta blockers due to hypotension, and then hypotension itself is a poor prognostic indicator. Patients who, as we mentioned, sort of in the European Society, have functional limitations, and lastly, those patients who are requiring higher doses of diuretics and have a progressive decline in electrolyte abnormalities are at risk for advanced heart failure. And then lastly, those patients who are developing frequent ICD shocks due to ventricular arrhythmias. So I know Dr. Buttar briefly discussed sort of the ideal time for referral for a patient with VAD, and I just want to briefly go over that again before we get into what exactly we do when we start the VAD evaluation. These patients, again, typically have New York Heart Association class 3 or 4 symptoms, sort of summarizing what we just discussed: functional limitations, electrolyte abnormalities, more specifically a low sodium level or elevated BUN. They are intolerant to guideline-directed medical therapy, are requiring higher doses of diuretics. We know that they are frequently hospitalized. And other than their ICD shocks, these patients also often we note that they are CRT non-responders. When we sort of they've looked at a sort of cohort of studies that looked at risk factors for advanced heart failure and sort of mortality risk. And you can see the common theme in red is the things that we've discussed. So hemodynamic compromise, more specifically hypotension, electrolyte disturbances, more specifically hyponatremia, and then elevated creatinine levels, elevated BUN levels, and lastly, frequent hospitalizations. So just key points to keep in mind in terms of when to evaluate, when to send someone for evaluation. Just to briefly discuss a couple studies, we know that patients who were on high dose diuretics and are unable to tolerate ACE inhibitors have a significant mortality risk. And those patients who are intolerant to ACE inhibitors in general tend to have more frequent hospitalizations for heart failure. When they looked at the ADHERE registry, which is the Acute Decompensated Heart Failure National Registry, when they looked at patients who were hospitalized for heart failure, they found that the patients that were at greatest risk for mortality were those that had an elevated BUN, hypotensive, and an elevated creatinine. We know, as Dr. Buttar mentioned, that those patients who are in medical therapy alone, more specifically inotropes, that they have an overall poor prognosis with a greater than 50% mortality in 1 year while on inotropes. The prognosis of patients on chronic inotropes, dobutamine or milrinone infusions over time does have a mortality risk. And so we really want to be able to evaluate these patients for advanced heart failure therapies. More specifically, when we're looking at sort of the clinical criteria for LVAD, we want to see patients who are New York Heart Association class 3 for heart symptoms. These patients are refractory to optimized medical therapy and usually have one of the following to sort of depict their functional status. They will have an exercise VO2 study, which shows a peak VO2 of less than 14 or a percent of predicted peak VO2 of less than 50% for age. These patients may be dependent on inotropes or on some sort of temporary mechanical circulatory support or ECMO. These patients have recurrent pulmonary edema within the past 6 months. They can present with cardiac cachexia. And then lastly, as we discussed, sort of symptomatic ventricular arrhythmias and progressive evidence of end organ dysfunction and electrolyte disturbances. When we're considering a patient for LVAD therapy, there's typically 3 categories that we're sort of evaluating these patients to assess sort of what we are using this device for. 26% of the population is now receiving an LVAD as a bridge to transplantation. So these patients are patients who are often, patients who are too sick to wait on a transplant list, especially here in Michigan due to our long wait times for donor organ availability. So we use the LVAD to sort of strategically get these patients to transplant safely and in a healthier state than they would without LVAD. But the most common reason that we are using the LVAD therapy now is for destination therapy, or what we call sort of the lifelong durable alternative for patients who are not candidates for cardiac transplantation. So these patients are living with an LVAD for the rest of their life and has been shown to be quite durable over time. Around 24% of patients sort of fit in that category of neither bridge to transplantation or destination therapy. These are patients that we often refer to as a bridge to candidacy or bridge to decision. These patients may undergo a transplant evaluation and find that they may have some barriers to transplant, but we can safely use the LVAD to get them to transplantation once they've overcome those barriers. Or these patients are patients that we may have an acute diagnosis of heart failure and are using the LVAD sort of as a long-term bridge to recovery in order to assess if their heart failure improves over time in the setting of some sort of acute insult. Current indications for an LVAD as bridge to transplantation are sort of what we just went over in terms of class 3, 4 heart symptoms. Again, looking at that peak VO2 of less than 14, either on inotropes or on temporary support. These patients in the past, we did use a heart failure survival score to sort of estimate their risk. And then lastly, they usually have an ejection fraction of less than 25% or a cardiac index that's less than 2.2 net on inotrope. They have to have met one of the following criteria in terms of being on optimal medical management for heart failure, or at least an attempt to be for the last 45 out of 60 days, or they have to have had heart failure for at least the past 14 days and possibly dependent on some sort of temporary device for at least the last 7 days. Indications for destination LVAD therapy are essentially the same criteria, except that these patients are not candidates for cardiac transplantation. So going into sort of the LVAD workup, and when we begin our VAD evaluation, I like to think of it as sort of looking at the body as a whole, because we are looking at multiple organ systems when evaluating these patients. And I think that some people don't really realize how in detail this evaluation can be. So I like to sort of think about it in terms of systems and how we evaluate each patient in terms of organ systems. The tests that these patients sort of generally will receive, if they're being evaluated as an outpatient, we typically start with an exercise VO2 test, metabolic stress test, sort of assess the amount of oxygen that they're needing while exercising, and then using those scores to determine how advanced their heart failure is. These patients then will go on to receive a right heart catheterization to assess hemodynamics, which we will discuss. Depending on their cardiac anatomy, they may also be receiving a left heart catheterization as well. They undergo a slew of laboratory tests to sort of determine their end organ function and blood type, and in terms of assessing their pulmonary reserve, all patients will undergo a pulmonary function test, especially if they were a prior smoker. We are looking for any evidence of peripheral vascular disease. If they were a prior smoker, they will undergo an abdominal ultrasound as well to assess for any aneurysms. Every patient prior to an LVAD undergoes a screening colonoscopy. And then lastly, patients, which many referrings don't realize we do, is that they have to undergo a dental clearance in order to be evaluated for a VAD. And we really want to ensure that these patients have good oral health to try and decrease risk of infection with their VAD prior to receiving the VAD therapy. The patient will then go on to have a sort of a psychosocial evaluation where they may meet with one of our palliative care specialists and psychologists if needed, as well as a social worker, and then someone from our team is, sort of ensuring that we have the insurance coverage for VAD therapy to ensure that we're able to cover the cost of surgery as well as testing and medications after VAD therapy. So we are going to briefly just sort of go over what all these tests entail and what we do. Essentially, the selection and timing of VAD placement is really critical. And so when we are evaluating these patients for VAD therapy, we are trying to assess sort of their operative risk and how likely they are to have a good outcome from VAD therapy. Obviously, we want to ensure that they have the benefit of long-term outcomes and have the social support and rehab potential that they may need, as well as possibly moving on to cardiac transplantation if needed. Some of the overall risk factors for operative mortality include chronic RV dysfunction, moderate to severe malnutrition, severe liver disease, severe kidney disease, hematological abnormalities, significant COPD, a history of noncompliance, lack of inotropic therapy, and lastly, anyone who's ventilator dependent has a significant operative risk for mortality. When they looked at, I know Dr. Buttar briefly mentioned the rematch trial, which was the study that looked at sort of patients who had end-stage heart failure and randomizing them to VAD therapy versus medical therapy alone. They looked at sort of a post-rematch study and tried to determine risk factors for mortality. And what they found was that the following 4 were really significant risk factors for mortality. Number 1, nutrition, which can lead to worsening infection post-op. Renal dysfunction, which can lead to, eventual renal failure. Coagulopathy, which increases bleeding risk during VAD therapy. And RV failure, which can lead to worsening RV failure on VAD therapy. So we really try to optimize these 4 risk factors prior to surgery. We start by assessing these patients' hemodynamics. So all patients prior to VAD therapy will receive a right heart catheterization. More likely than not, they do have a PA catheter inserted prior to surgery with continuous monitoring of hemodynamics. And what we're looking for is ways to increase their cardiac output and cardiac index and optimize them prior to surgery. We will use inotropes and a balloon pump if necessary. We are trying to prevent further end organ injury and sort of optimize end organ function prior to surgery. Ideally, we are trying to decrease our central venous pressure to less than 15 to further minimize hepatic congestion and minimize cardiorenal syndrome. These patients will be diuresed until we can achieve these measures. We are also trying to maintain ways to decrease pulmonary vascular resistance, which can lead to worsening RV failure. And as we are doing this assessment, we're assessing whether they will need some sort of temporary right-sided support, or are we moving on to transplant and VAD therapy won't be an option. When assessing the right ventricular function, we know that RV failure contributes in the long run to decreased LVAD filling and low output. It can further lead to hepatic congestion, worsening bleeding on VAD, worsening renal failure, ventilator dependence post-op, eventually leading to multi-system organ failure. These patients with RV failure tend to have longer ICU stays and prolonged hospitalizations. When we looked at sort of RV failure and RVAD use over time, the technology has gotten pretty good with VAD therapy. And so as time has gone on, we have had to use RVADs less than when we initiated VAD therapy. And so I think that as a whole, centers are more cognizant of the fact of sort of assessing prognostic indicators for RV failure and trying to ensure that patients have good outcomes and that good RV function can be maintained while on VAD therapy. RV failure in HeartMate 2 patients, when they looked at sort of the incidence, risk factors, and effect on outcomes, what they essentially found was that those patients who had RV failure post-implantation did have significant lengths of stay post-operatively. And so we are trying to minimize that and assess that prior to surgery. Predictors of RV failure during LVAD support. In this study, they found multiple sort of relative risk factors for RV failure during LVAD support. These included, as we've mentioned, being on a ventilator, and then sort of more specifically looking at certain hemodynamics. So during a right heart catheterization, we will look at the RV stroke work index, and if it's less than 300, that is a significant risk. We also look at our CVP to wedge ratio. greater than 0.63 is a risk, and then electrolyte abnormalities and laboratory abnormalities in terms of lower hematocrits, elevated white cell count, and then elevated CVP and creatinines, as well as more specifically to note small body mass index in females. And when they looked at the HeartMate 2 trial, what they found were independent predictors of RV failure was that if a patient was on a pre-op ventilator, whether their CVP to wedge ratio was more than 0.63, and if their BUN was greater than 39. Univariate predictors included an RV stroke work index of less than 300, a CVP of more than 15, and an elevated BUN and white cell count. When we are evaluating sort of the RV and its overall function, we do look for certain parameters and try to obtain a desirable value for those parameters. We're looking for an RV stroke work index of greater than 300, a CVP of less than 15. We're trying to minimize tricuspid regurgitation, decrease our pulmonary vascular resistance and transpulmonary gradient to less than 4 and less than 15. If we can, we try to decrease our RV size, and we try to avoid the need for preoperative ventilator support. In terms of management of the RV pre-VAD, we need to know the hemodynamics. It's critical that we get the CVP below 20. In ways that we're sort of treating pulmonary hypertension and RV failure other than diuresis is we will use inotropes, we will use nitroprusside, and if needed, ultrafiltration. 24 hours before surgery, some patients may go on to receive an elective balloon pump, and that just sort of helps LV unloading, lessen ischemia, and may improve pulsatility and decrease our need for RVAD or prevent RV failure. All patients will undergo pulmonary function tests, and these patients, although there's no absolute criteria for exclusion on a pulmonary function test, what we're essentially looking for is that severe COPD may be a contraindication, so a relative contraindication. We're looking sort of for the FVC, FEV1, DLCO, if less than 50% predicted, that could be a relative contraindication. Mechanical ventilation predicts RV failure and poor outcomes, so we are again trying to avoid patients who are on preoperative ventilators. Patients who come in with arrhythmias, pre-VAD can sort of fit into two categories: those who have very high filling pressures and those who have mildly elevated filling pressures. And the ones that when we talk about ventricular arrhythmias, those who come in with very high filling pressures, we are trying to sort of improve those hemodynamics prior to VAD therapy. We will use aggressive diuresis, possible balloon pump if needed. Likely these high filling pressures are sort of hemodynamically driven arrhythmias, and so we are trying to improve those so that we can expect that there would be a persistent benefit post-VAD. Now, the patients who come in with ventricular arrhythmias and only have mildly elevated filling pressures, these are the patients we worry about who may not improve with VAD therapy. So likely their ventricular arrhythmias are not hemodynamically driven, and there's concern that the ventricular arrhythmias may persist post-VAD therapy. And so oftentimes these patients are the ones that we're ideally trying to get on to transplant or may need some sort of consideration for biventricular support temporarily. In terms of sort of the cardiovascular organ system in general, any patient who has an artificial mechanical heart valve in the aortic position that cannot be converted to a bioprosthesis could have relative contraindication to VAD. If they have an untreated aortic aneurysm, that's something that could be a contraindication to VAD. And then any type of severe uncorrected peripheral vascular disease or any type of limb-threatening ischemia could be a contraindication to VAD. When we're assessing patients who we are concerned for malnutrition, we do use certain markers to let us know how severe their malnutrition is. If they have a BMI of less than 20, an albumin of less than 3.2, a prealbumin of less than 15, transferrin greater than 250, or total cholesterol less than 130, or lymphocyte greater than 100 could be suggestive of severe malnutrition. Pre and post-operative nutritional support. So all of these patients that we are concerned about, their nutritional status, will meet with a dietitian nutritionist in the hospital. It's really critical that we try to optimize that prior to surgery. So if oral supplements are not enough and they're not able to meet their caloric needs, we will consider DAB-HOF and tube-HOF feedings before surgery to optimize their nutrition. Very rarely are we using total parenteral nutrition just because of the risk of infection, but ultimately nutrition is a significant factor that goes into sort of optimizing factors prior to VAD therapy. Now, obesity itself is not a contraindication for VAD therapy, but it is a contraindication for transplant. We know that these devices can provide adequate support. In the initial trials, when they looked at patients for bridge to transplant and destination therapy, they used a BMI cutoff of greater than 40, but ultimately some centers do not have a BMI cutoff. And so we know that these patients can thrive with VAD therapy. However, it's the patients who are cachectic and have a BMI of less than 22 who are at high risk for surgery, especially if they have a prealbumin of less than 15, which is greater risk for mortality. So it's actually the patients who go on to develop cardiac cachexia that we worry most pre-VAD and really need to optimize prior to surgery. If the patients have any type of indwelling catheters prior to surgery, we are constantly making sure that our infection risk is low. They're evaluated if they're febrile for any type of systemic infection. All lines are replaced with new lines prior to surgery and new access sites at least 36 hours before surgery. They all get a swab, a nasal swab for Staph aureus preoperatively, and if they are positive, they are treated. And as I mentioned earlier, all patients undergo a dental evaluation to ensure that they have good oral health. Any patient who's had any type of sort of recent infection, we do worry about that and try to address that that's been treated correctly prior to surgery. Now, each center is different in terms of antibiotic prophylaxis that is being used pre-operatively, and this is a summary of those that are most commonly used throughout the US. So centers are using the following antibiotics to sort of ensure that our post-operative infectious risk is low, and as I mentioned, if they do have a nasal swab that's positive, they will be treated. When assessing renal function as an organ, predictors of poor outcome, as I mentioned, are creatinine more than 2.5 and a BUN greater than 40, usually a GFR that's low, less than 50, a urine output that's less than 30 continuously, and we try to rule out any type of intrinsic renal disease. We optimize renal perfusion, try to lower the CVP. These patients are on aggressive diuresis, and ultimately it's a fine line when we're trying to decide if renal function may improve once our hemodynamics have improved. Now, looking at sort of overall hepatic function and coagulopathy, it's very important that we determine the etiology of dysfunction that could be contributing to hepatic function. So these patients all have LFTs done, serologies. If there is concern on ultrasound of the liver for cirrhosis, we will proceed with liver biopsy with our liver team just to rule out end-stage cirrhosis. If all hepatic labs are within normal limits, then we want to, and could be related to sort of a cardiohepato syndrome, then we want to make sure that they're well compensated prior to surgery. The minimum screen for coagulation includes having PT, INR, PTT drawn, platelet count, they can have platelet aggregation studies, and a HIT assay if there is concern for HIT. Overall coagulation management, we know that optimizing hemodynamics can improve coagulation. So we really want to make sure that we're decreasing our pulmonary vascular resistance and right heart pressures. We are trying to decrease and unload any type of hepatic congestion If the patient preoperatively is on Coumadin, aspirin, or Plavix, we do try to stop those well in advance if possible. Warfarin will be changed to heparin infusion prior to surgery. If the patients need vitamin K and FFP, it can be used. And if the patients are being evaluated for heparin-induced thrombocytopenia, then we will consider alternative anticoagulants preoperatively. So in terms of looking at overall parameters, essentially our goal sort of per system here is that in renal function, we're looking to achieve a GFR that's greater than 50, have our serum creatinine less than 2.5, and a BUN of less than 40. In terms of hematological parameters, we're looking for an INR of less than 1.2, a hemoglobin of greater than 10, and a platelet count of greater than 150. Nutritional factors, we're looking for a pre-albumin of greater than 15, an albumin greater than 3, and a transferrin greater than 250. In terms of liver and hepatic function, we want a total bili of less than 2.5, an ALT, AST of less than 2 times normal, and an INR hopefully less than 1.2. And then hemodynamics in terms of the RV, we're looking for an RA pressure of less than 15 and a wedge of 24. So this is what we're really trying to achieve preoperatively. Other things that are involved in our workup, GI bleeding assessment. So all patients will undergo a screening colonoscopy prior to VAD therapy, and we want to sort of consider the long-term effects of anticoagulation therapy during support. If they've had a prior sternotomy, they will have another CT of the chest to assess their anatomy. And if they have peripheral vascular disease, they will undergo an abdominal ultrasound, ABIs, as well as a carotid ultrasound. Overall, sort of looking at sort of the neurological function and psychosocial psychiatric considerations. So what we're really trying to achieve here is sort of assessing candidates' ability to care for equipment and exercise. Are these patients going to long-term thrive with VAD therapy? If they have a history of a prior stroke, it's not necessarily a contraindication depending on the timing of when the prior stroke was. And really, we're looking to make sure that they have enough social support from family members if they do have limitations or muscular diseases that contribute to limitations that would be able to support them while on VAD therapy. Patients who have a history of psychiatric disorders, drug abuse, or compliance issues may need a commitment contract in some instances. And then ultimately, we are trying to ensure that everyone has the support they need to thrive, because living with a VAD is very difficult if it's like a one-man show. And so it really takes a village to sort of help support these patients. Which leads to sort of that psychosocial psychiatric evaluation. So every patient will meet with a transplant social worker, VAD social worker prior to implantation. It's a detailed psychosocial evaluation, just sort of ensuring that patients understand what it's like living with a VAD, ensuring that they have the availability of caregivers to help them at home. Are they able to cope and sort of deal with stress management, and how compliant are they? Can we ensure that these patients will be successful with VAD therapy? And lastly, a big shout out to our VAD coordinators who spend a significant amount of time preoperatively educating these patients about what VAD therapy is. So they'll meet with a VAD coordinator to see a pump, an example of a pump, sort of understand how it works, assess what the batteries are like, what the controller is like. And in some instances, they may even meet a patient who has a VAD to ask questions about what life is like living with a VAD, and sort of get a better understanding of what VAD therapy is like. Once all of this testing and sort of evaluation is complete, it's important to know that this is not, a one person making a decision on whether a patient is a candidate for VAD therapy. It's really a multidisciplinary team comprised of surgeons, our cardiothoracic surgeons, our heart failure cardiologists, our nurses, social workers, psychiatrists, our VAD coordinators, financial counselors, who meet as a group to determine whether each patient is a candidate for VAD therapy. So it is a multidisciplinary team that sort of assesses patient selection for VAD therapy. So just to sort of summarize our preoperative optimization and sort of the key takeaways of what it takes to implant a patient with a VAD and what we do to get patients successful VAD therapy. As I mentioned at the beginning of talk, really the key here is proper patient selection and sort of the timing of implant. That's really the key to our success. And we know that based on current data, that the earlier we implant patients with VAD, the better outcomes we have. We really focus on sort of that pre-implant optimization of ensuring that the RV will be good enough for VAD therapy, improving their nutritional status to ensure that their infection risk is low, assessing sort of the patient's current severity of illness and how will they respond to pre-op optimization, and then ultimately ensuring that the patient has sort of that system around them post-operatively to manage equipment and care for the patient to ensure their success. So I want to thank you all. I know it's a long process from the start to the beginning of when we actually evaluate a VAD patient, but when our patients come in critically ill, it's amazing how well our team quickly is able to achieve all this, sometimes within 24 hours, to really get a patient to where they need to be when they're that sick.
Thank you so much, Dr. Hasan. Simona Butler from pharmacy put a comment in the chat for a clarification of pre-op antibiotic prophylaxis, which is vanco and ceftriaxone pre-incision, and post-operatively, we use levofloxacin, fluconazole, and rifampin times 48 hours, and then vanco until chest tubes are removed.
Thank you for clarifying that. Yeah, I think every center is different, but this is what our center does.